Good evening, everyone. This is the new batch of MRCP that we are beginning today, and we will be beginning with the endocrinology syllabus, the first lecture of the series, that is pituitary. For further details, these notes and this content is provided by Dr. Bhatia's Academy. The content has been prepared by Dr. Bhatia himself, and it is based on the latest edition of Harrison's Internal Medicine, the Principles of Internal Medicine. To download the app, you can scan this QR code, and for all the free demo videos, you can go through all the videos. And for joining the subscription to MLE, MRCP, or Smart Medicine, you can join the subscription as well. So beginning with pituitary disorders, first of all, we must know the embryology of the pituitary gland. So pituitary gland, as we all know, has two parts, rather three. One is the anterior pituitary and the posterior pituitary. And between the anterior pituitary and the posterior pituitary, there is some intermediate lobe also. But this intermediate lobe is not functional, not physiologically of any significance. So we only talk of anterior pituitary and the posterior pituitary. Anterior pituitary, which is also known as adenohypophysis, it develops from the surface ectoderm near the mouth. So it develops from the roof of the stomatium by forming a Rathke's pouch. So if it persists, it might result in craniopharyngioma. So this is the most common pituitary mass of the childhood or in children's age. Posterior pituitary, also known as neurohypophysis, it is derived from the neuroectoderm. So we'll have a look at it. So this is the stomatium, and the surface of the stomatium, it bulges to form the Rathke's pouch, and this Rathke's pouch forms the anterior pituitary. It gets separated from the surface of the stomatium and it forms the anterior pituitary. And this is the downward movement of the infundibulum, and this will give rise to the posterior pituitary, that is a neurohypophysis. So this is a neurohypophysis and this is the adenohypophysis, and the two put together form the pituitary gland. And in between you can see there is a pars intermedia, the point where the posterior and the anterior join, that is the pars intermedia. Now pituitary along with hypothalamus orchestrates most of the hormonal functions of the human body, and that is why we call pituitary as the master gland. So we must understand the hypothalamic pituitary axis. To understand the hypothalamic pituitary axis, let us suppose this is the hypothalamus. So most of the releasing hormones and the inhibitory hormones, they come from the hypothalamus. So hypothalamus giving rise to thyrotropin releasing hormone, that is TRH. TRH will act on the pituitary, anterior pituitary, and release TSH, that is thyroid stimulating hormone. TRH also stimulates prolactin. That is why whenever you have a thyroid disorder, you also find a rise in the prolactin. Then there is dopamine, which is having an inhibitory influence on the prolactin. So the red arrows mark negative, that is inhibition, and the green arrows mark positive, that is stimulation. So dopamine will inhibit prolactin. It keeps prolactin under inhibition. Similarly, somatostatin from the hypothalamus causes inhibition of the TSH as well as the growth hormone. So somatostatin also keeps the two hormones under inhibition. Gonadotropin releasing hormone will stimulate gonadotropins, that is LH and FSH from the anterior pituitary. GHRH, that is growth hormone releasing hormone, will stimulate the growth hormone, and corticotropin releasing hormone will stimulate the adrenocorticotropic hormone from the anterior pituitary. So now this hypothalamic pituitary hormone axis, once again we'll revise. CRH will stimulate ACTH and MSH and beta endorphins. Dopamine will inhibit prolactin and TSH. Growth hormone releasing hormone will stimulate the growth hormone. Gonadotropin releasing hormone will stimulate LH-FSH. Prolactin keeps a negative influence on the GnRH, that is gonadotropin releasing hormone. And somatostatin also inhibits growth hormone and TSH, and TRH stimulates TSH and prolactin. So TRH rise as seen in both primary hypo as well as secondary hypothyroidism, is associated with a rise in prolactin. Now, the pituitary gland, that is the anterior pituitary or the adenohypophysis, it secretes major hormones, that is the 6 major hormones, that is prolactin, LH, FSH, ACTH, TSH, and GH. Now, how do you remember them? You remember them as G, T, A, P. The GG tab. The GG tab, that is growth hormone, gonadotropin, TSH, ACTH, and prolactin. MSH is another hormone secreted from the intermediate lobe. Basically, it comes from the pro-opiomelanocortin, which splits into MSH also. This is derived from the oral ectoderm, that is Rathke's pouch. We just studied how it is developed. The anterior pituitary is coming from the Rathke's pouch. Now, ACTH and MSH, they are both derived from pro-opiomelanocortin, that is POMC. Now, how do you remember the hormone? There is some mnemonic called flat pig, that is FSH, LH, ACTH, TSH, prolactin, and the growth hormone. Out of this, B flat. So, B flat means the flat hormones are coming from the basophilic cells. They are basophils. And the remaining two, that is growth hormone and the prolactin, is coming from the acidophils. So you have a flat in the B block, or you can say just you should be flat. So FSH, LH, ACTH, and TSH, they are coming from the basophilic cells. Posterior pituitary, that is neurohypophysis, it will not form hormones, it only stores hormone which come from the hypothalamus. So it stores the hormones and releases the hormones that are made in the hypothalamus, that is supraoptic and the paraventricular nuclei, and they are transported to the posterior pituitary via neurophyzins. That is, they are the carrier proteins. And this posterior pituitary is derived from the neuroectoderm. We just saw that it comes down, whereas Rathke's pouch is invaginating. This is downvaginating. Now, what are the pituitary adenomas? Any mass of the pituitary, any of the cell can become hyperplastic, and there will be a pituitary adenoma. Most of them are benign. And the most common pituitary adenoma is a prolactinoma. It is arising from the lectotrophs. Then adenomas, they can be functional, that is hormone producing, or at times they are a non-functional pituitary tumors, which we commonly call as NFPT, the non-functional pituitary tumors. Now, the non-functional pituitary tumors, they may present with mass effect. They may not be producing the hormone, but they will still be occupying the space and they may produce the mass effect. So this pituitary is actually lying in the sella, and this sella is a small bony cage with a cavernous sinus here and the carotid arteries and not many organs around, with the optic chiasma just passing above it. So if this tumor is present and may not be producing hormone, still it can produce a mass effect, that is the compression effect. If it rises on the superior side, that is on the upper side, and compresses the chiasma, it might cause bitemporal hemianopia. Or if it is occupying the whole of the space, the normal cells are not able to produce the normal hormones, there will be hypopituitarism. Then because of the stretch effect, it can also cause headaches. Functional tumors will present depending upon which hormone they are producing. So that is depending upon which hormone, which cell is the tumor or the adenoma is arising from, that will be responsible for the clinical features. So let's talk about acromegaly first. That is a growth hormone producing mass. So this is a pituitary. You can see this is a pituitary here, and this pituitary adenoma has gone upwards. So this pituitary, this is a sella, and it is increased in size, and the pituitary has gone up. So there is pituitary adenoma, and this pituitary adenoma happens to be a growth hormone secreting adenoma or a growth hormone producing adenoma. So GH adenomas, they are almost 20% of all the pituitary adenomas, and it will release growth hormone. So it will have excess growth hormone in the system. Excess growth hormone will go and stimulate the liver synthesis of IGF-1, that is insulin-like growth factor 1. Now, anti-insulin amino acid uptake in muscles also is increased. It stimulates gluconeogenesis. We all know GH is going to produce more of glucose. There is insulin resistance and there is hyperglycemia. So it produces gluconeogenesis. Then the negative feedback relation, there is a negative feedback relation. Most of the endocrinology, is based on negative feedback relations. So it has a negative feedback relation with glucose and IGF-1, but this negative feedback relation in case of GH producing tumors is lost. So you do an OGTT to diagnose the condition. You give more of the glucose, still the GH is not suppressed. That is negative feedback is lost. So hyperglycemia, normally it inhibits growth hormone, whereas hypoglycemia, it stimulates the growth hormone. Similarly, anti-natriuretic action. It has an anti-natriuretic action. That is, it will not allow the sodium to be lost. So it retains sodium. Then the IGF-1, it functions normally to increase the linear growth of the children. So it stimulates the growth of the bone, that is the linear growth, as well as the lateral growth. There is growth of the cartilage also and the soft tissue also. So IGF-1 works through signal pathway for IGF-1 is receptor tyrosine kinase. So we will learn more about the hormone receptors in the chapter when we discuss the mechanism of hormone action. So signal pathway for IGF-1 is tyrosine kinase. Now, some basic concepts about growth hormone. Growth hormone, which is also known as somatotropin, it is secreted in a pulsatile manner. So most of the pituitary hormones are secreted in a pulsatile manner. Growth hormone releasing inhibitory factor, that is GHRIF, which is somatostatin. Somatostatin comes from hypothalamus. We just studied. Somatomedin is IGF-1. So somatomedin is the hormone which is stimulated by the growth hormone, and it goes and acts at the peripheral end organ. Somatomedin C, it is produced when stimulated by somatotropin, that is growth hormone, to mediate its effect. It is also known as IGF-1. It's a potent growth and differentiation factor. But defective growth hormone receptors will lead to decrease in the linear growth and is called the Laron's dwarfism. So if the defect is at the GH level, that is, there is no hormone, we call it a GHD, that is growth hormone deficiency. If the defect is at the receptor level, that is, the GH is high, but the receptors are absent, there are no receptors in the end organ, then that condition is known as Laron's dwarfism. And we still don't have the treatment for Laron's dwarfism with us in our country. It is characterized by high serum levels of the growth hormone and low IGF-1. The GH is high, but because the receptor is not allowing the GH to work, as a result, even IGF-1 is not produced. So low IGF-1 in the presence of high GH is suggestive of a receptor defect. Increased GH is caused by fasting, L-arginine, exercise, deep sleep, and puberty. Now, pathophysiology of acromegaly. Because of the pituitary adenoma secreting growth hormone, this growth hormone secretion, if it occurs in childhood, that is prior to the bone fusion, prior to the skeletal epiphyseal closure, it will cause gigantism, that is increased linear growth as well as increased lateral growth. But if the secretion begins after epiphyseal closure, that is in adulthood, it will lead to acromegaly, that is, there is only increase in the lateral growth. In that condition will be marked by frontal bossing. So the forehead will be very prominent and the jawline will be very, very prominent. So frontal bossing of the forehead and the prominence of the jaw, the prominent jawline. So because of the excessive growth before the epiphyseal closure or in childhood will cause tall stature, that is gigantism. Whereas in adulthood, it will be marked only by lateral growth. So you will find that the ring size, the patient complained that my rings are getting tight, my shoe size is changing every month. So if that is a complaint, then you are dealing with acromegaly. So this is the jawline that becomes the jaw becomes prognathism. This is called protrusion of the jaw. That is prognathism or a protruding jaw. There will be, because the jaw is becoming enlarged laterally, the teeth become separated. So you will find that the there is separation in between teeth. There is deepening of the voice. The joint abnormalities are very evident because of the unusual growth of the articular cartilage. So because of the cartilage defects, the joint abnormalities are quite evident. Then because of the thickening of the soft tissue, there is carpal tunnel syndrome. So the reticulum, which is holding both all the tendons of the hand or the wrist together, that reticulum becomes tight because of the soft tissue swelling, and there is carpal tunnel syndrome. You will also find proximal muscle weakness. GH is often co-secreted with prolactin. So there is amenorrhea and erectile dysfunction from the increased prolactin. Mass effect, as we were discussing, because of the pituitary enlargement, it is within the sella. So it will, because of the stretching effect, it will cause headaches. If it increases upward, it will compress the optic chiasma and there will be bitemporal hemianopia. If it expands laterally, it will also cause blockage of the internal carotid arteries, or even you will find there is a cavernous sinus compression. So diabetes happens as one of the complications of the GH secretion because growth hormone causes insulin resistance. It is counter-regulatory to insulin. It is an anti-insulin hormone. It raises the blood glucose. It also affects the proteins and amino acids, but these actions are all mediated via IGF-1. Now, at the vascular level, it will cause rise in the blood pressure. It will cause left ventricular hypertrophy and cardiomyopathy. So the most common cause of death, if somebody asks you in the question, the cause of death in acromegaly is cardiovascular system. That is, it is either CHF or it is hypertensive cardiac failure. GH or acromegaly is also associated with malignancy, and colon cancers are very common. They are associated with increased development of colon cancer, colonic polyps. So colon cancers and polyps are quite evident at times, and sometimes a patient presents with colon polyps also. There is, if you try to evaluate the patient now, so the investigation part, you have to measure the heel pad thickness. So there is increase of the heel pad thickness, which is seen on X-ray lateral view. You will find that there's a soft tissue enlargement so much that the heel pad thickness is increased. This is a very important point because the most common cause of increased heel pad thickness is otherwise heel injury. Suppose there is no other symptom of GH, but the heel pad is increased. So that does not mean acromegaly. The heel pad increased, most common cause is heel injury. But in acromegaly, in the absence of heel injury, there is increased heel pad thickness. The screening test is at times serum prolactin. If the serum prolactin is very, very high, then probably if the clinical features are also pointing towards acromegaly and there is a rise of prolactin, probably we are dealing with GH adenoma. Then comes the biochemical test, and the best biochemical test is raised IGF-1. So usually it is more than 5 times the normal. Then you go for a stimulation test, endocrine dynamic tests, what we call. So in case of GH tumor, we do a GH suppression test. So it's a basic fundamental rule of endocrinology. If any hormone is produced more, you do a suppression test. You try to suppress it. And if you fail, you are dealing with a tumor. Similarly, if any hormone is deficit, you do a stimulation test, that you try to bring the hormone up. If it does not come up by your efforts, you are dealing with a hormone deficiency. So here we are dealing with a growth hormone excess. So we will do a suppression test. So we will do an OGTT. The serum growth hormone does not get suppressed following oral glucose, and that is the most confirmatory test. So you give us 75 grams of glucose, and after 1 hour, if the growth hormone is still above 1 nanogram per ml, then we are dealing with a GH tumor. So you do one MRI pituitary with contrast, or you can also do a CT, and you will find that there is enlargement of the sella. So if the serum hormone level is supporting your diagnosis, and you have a radio imaging diagnosis also supporting your biochemical diagnosis, then you have the correct diagnosis with you. So coming to the treatment, GH secreting tumors, they respond to medical management. That is somatostatin analog. So we have the somatostatin analog, that is octreotide or lenriotide, which are the long-acting somatostatins. You can also use dopamine agonists for prolactin suppression, that is bromocriptine or cabergoline. The GH receptor antagonism, that is at the peripheral level. If you want to try the GH receptor antagonism, that is pagvisomant, but that is not a first choice, first line of drug. It is a second best treatment. It will block the endogenous GH action by blocking the peripheral GH receptors, but the GH levels will still remain high. Consequently, the IGF levels are suppressed and the side effects or the clinical effects of IGF-1 are suppressed. Otherwise, you go for surgery. So if the tumor mass is more than 1 centimeter, we call it macroadenoma. So if it is a macroadenoma, then you go for a transsphenoidal surgery. So usually the treatment of choice is surgery and transsphenoidal. So you enter by the nose, through the nose, you penetrate the diaphragm sella, the diaphragm of the sella you penetrate and you enter the sella. And inside the sella, you catch hold of the adenoma and you come out of the same route. So transsphenoidal surgery, which is the most effective treatment, and it is seen that the clinical success rate is around 70%. Then you can also, after the treatment, if you feel that the mass was very big and there is some remnant with the sella inside, you can also go for radiotherapy. If surgery is inappropriate, you can also choose radiotherapy as your first line management. But radiotherapy may take some years to be effective. Just a quick revision of the GH tumors. LMRP, that is the last minute revision points. LMRP is the USP of DBA. So basic physiology, growth hormone is a somatotropin. Growth hormone releasing inhibitory factor, somatostatin. Statin, anything which is static does not work, static. So it is inhibitory factor. Somatomedin, which is made by the growth hormone, that is IGF-1. Clinical features, tall stature, excessive growth of hands and feet, prognathism, teeth separation, joint abnormality, carpal tunnel syndrome, proximal muscle weakness, GH co-secreted with prolactin causing amenorrhea and ED, local effects of the pituitary tumor causing headaches, visual field loss, complications, diabetes, cardiovascular complications, and colon cancer. Treatment investigations, increased heel pad thickness, screening test is prolactin, elevated IGF-1, the best initial test. OGTT is the endocrine dynamic test, which is most confirmatory. Localization by MRI or CT. Treatment, medical management, somatostatin analog, that is octreotide, dopamine agonist, cabergoline, GH receptor antagonist, that is pegvisomant, surgery, which is transsphenoidal surgery, or radiotherapy. That was about GH tumors. Coming to the prolactinomas. Again, a quick revision of the axis, the hypothalamic pituitary axis. So this is the prolactin. This remains in the inhibitory control of dopamine. This prolactin in return keeps GnRH in the inhibitory control. Okay. So just remember this, dopamine has an inhibitory control over prolactin and prolactin has an inhibitory control over GnRH. So prolactin is a 199 amino acid peptide secreted by the lectotroph cells of the pituitary. Prolactin is responsible for milk production, that is lactation in the postpartum women. Increased serum levels of prolactin in men or women from any cause will cause suppression of the GnRH, because we just learned it keeps GnRH in the suppression of the negative effect. Signal pathway for prolactin is non-receptor tyrosine kinase. So again, prolactin and IGF-1 also we read, the receptor is, the mechanism of action is tyrosine kinase. So prolactinoma will cause hyperprolactinemia and hyperprolactinemia will cause galactorrhea. So galactorrhea is spontaneous flow of milk from the breast, which can be male or female. So it includes males also and females also. So any women with increased flow of milk without pregnancy, without lactation, we label it as galactorrhea. So TRH also has a stimulatory effect on prolactin. We just read. Dopamine has an inhibitory effect, and prolactin has an inhibitory effect on GnRH. So once again, TRH has a stimulatory effect on prolactin, and dopamine has a negative effect on the prolactin. This prolactin has a renal clearance. It is cleared by liver and kidney. Estrogen also has a positive or a stimulatory effect on prolactin, and that is why prolactin levels are raised in pregnancy and lactation. There's something called a stalk section effect. So if I cut it from here, this is stalk section. The pituitary stalk is cut. What will happen? I will lose the inhibitory effect of dopamine. So if I lose the inhibitory effect of dopamine, prolactin will rise. So that is called the stalk section effect. So sometimes we find that the pituitary is cut or lost, or there's a mass which is compressing the pituitary stalk, and that is why the prolactin is raised. So hyperprolactinemia may result from excess production from the pituitary, that is prolactinoma, which is the most common hyperfunctioning pituitary adenoma. Okay. You can also get hyperprolactinemia by a dopamine antagonist. So if you are giving a dopamine antagonist, that is metoclopramide, you will get a rise of prolactin. So important points are prolactinomas may co-secrete growth hormone. Just now we read growth hormones will co-secrete prolactin. So now reverse, prolactinomas will co-secrete growth hormone. So hyperprolactinemia, physiologically, pregnancy and breastfeeding, that is lactation. Drugs, metoclopramide, that is dopamine antagonist. Phenothiazines, haloperidol, methyl dopa, estrogens, verapamil. Certain diseases, most common prolactinoma, which is micro if it is less than 10 mm, macro if it is more than 10 mm. Stalk damage, we just read, because if there's stalk section, pituitary adenoma or surgery or trauma or craniopharyngoma will release the prolactin from the inhibitory action of dopamine. Then conditions like hypothyroidism because of the rise in TRH, CRF, and cirrhosis because of the decreased clearance of the prolactin peripherally. Hypothyroidism because of increased TRH causes increased prolactin. Cirrhosis and CRF because of the decreased prolactin clearance. Clinical features, because of the mass, it will always remain the same, that is headache. Visual field defects, that is bitemporal hemianopias. Because of the excess of prolactin, the direct effect of prolactin on the breast will cause galactorrhea. Reproductive dysfunction. Why? Because high prolactin will suppress GnRH. Because of the high level of prolactin suppressing GnRH from the hypothalamus, it will lower LH and FSH, leading to hypogonadism and ovulation and amenorrhea. As hyperprolactinemia causes hypogonadism, that is low estrogens in females, affected patients are also at higher risk of osteoporosis. So estrogen maintains the bone mass. So any loss of estrogen because of menopause or hormonal imbalances or the surgical removal of the ovaries, that is surgical menopause, it will cause osteoporosis. The low bone density and vaginal dryness are very common sequelae of the decreased estrogen. All of these causes of the low bone density, they should be ruled out in any patient coming to you with a significant low bone density. Postmenopausal women with prolactinomas are already amenorrheic and infertile. So they are presenting mainly with headaches and visual field defects. So a typical triad of amenorrhea, galactorrhea, and infertility should point towards prolactinoma. In males, they will have decreased libido, erectile dysfunction, infertility because of the hypogonadism. Galactorrhea may be present in 10% of the cases. Hypopituitarism occurs in 50% and is caused by mass effect of the tumor. GnRH stimulates the release of LH from the pituitary, which stimulates testosterone, and consequently suppression of the GnRH will cause low LH and low testosterone. I think this is very clear by now. So to investigate, very first is rule out pregnancy or lactation, then take a drug history, a detailed drug history, rule out hypothyroidism, kidney and liver failures, then measure the fasting serum prolactin, and it should be a pooled sample. If serum prolactin is more than 100, we are strongly suggestive of prolactinoma. But if the level is more than 200, we are most accurately diagnosing prolactinoma. With a low LH and FSH, decrease because of the decreased GnRH, decreased estrogen because of the FSH, and decreased progesterone because of the LH. Radio imaging will give you the similar picture. This is the sella, and this is the rise of the pituitary. You can see the huge mass which is compressing the chiasma. So microadenomas, that is less than 10 mm, macroadenomas, that is more than 10 mm. Treatment, you have to give any dopamine agonist. We are trying to suppress prolactin. So dopamine agonist, that is bromocriptine, or you can also use cabergoline. So they will decrease prolactin. Low prolactin will restore the menstrual cycles and decrease the tumor size. So cabergoline is now the drug of choice. It is once a week. It is more effective, less side effects, and is effective in 90% of the cases. Again, transsphenoidal surgery, that is only indicated if it is a macroadenoma and not controlled by drugs. Compressive symptoms already present. So surgery is more effective in macroadenomas. Recurrence occurs in more than 50% of the cases of macroadenomas. Radiation therapy is given for non-resectable macroadenomas. If the mass is too big, already adhering to chiasma or adhering to the sinuses, cavernous sinuses, we are not using surgery, we are using radiotherapy. This is the endoscopic transsphenoidal surgery. So last minute revision points for the prolactinomas. Prolactinoma will cause hyperprolactinemia and galactorrhea. Hyperprolactinemia may result from prolactinoma or administration of dopamine antagonist. So if you're already giving dopamine antagonist, that is drug induced. Causes of hyperprolactinemia can be physiological, that is pregnancy and lactation. It can be drugs, that is dopamine antagonist. It can be mass effect. It can be a pituitary adenoma, that is prolactinoma. It can be a stalk damage, that is stalk section effect, causing release of prolactin from the dopamine inhibition. And it can be hypothyroidism because of TRH and CRF and cirrhosis because of the decreased peripheral clearance. Clinical features because of the mass effects or because of the excess prolactin. Typical triad seen in women is amenorrhea, galactorrhea, and infertility. In males, there will be loss of libido, galactorrhea, and hypopituitarism. To rule out pregnancy and lactation before proceeding further, drug history, hypothyroidism, CRF, liver diseases, then check up morning fasting serum prolactin level, get one MRI to locate the tumor. Treatment is bromocriptine, that is dopamine agonist, cabergoline, go for a surgery or go for a radiotherapy. Coming to hypopituitarism. So what is hypopituitarism? So under secretion of the pituitary hormones. So far we were discussing excess of the GH, excess of the prolactin, that is a common pituitary adenomas. Now you will talk of GnRH adenomas, very, very rare, rarely talked. TSH adenoma, again, very, very rare, very less talked. Cortisol producing ACTH adenomas or the Cushing's disease, yes, that entity exists and that we will talk in some other class, not now. Here we are coming to low secretion of the pituitary hormones or the under secretion of the pituitary hormones, that is hypopituitarism. So non-secretory pituitary adenomas, that is craniopharyngiomas or the NFPT, which is only occupying the space, not producing any mass, not producing any hormone, only producing the mass effects. Then there can be Sheehan syndrome. Sheehan syndrome is postpartum. So postpartum, because of the excessive blood flow, excessive blood loss, postpartum hemorrhage causing ischemic infarct of the pituitary following a postpartum bleeding, or a pregnancy-induced pituitary growth, susceptibility to hypoperfusion. Usually it will present with failure to lactation. absent menstruation or cold intolerance. Cold intolerance, which is indicating towards secondary hypothyroidism. It can also result from brain injury or a brain radiation, which is given because of some other reasons, maybe for some other cranial tumors, we are using cranial radiation or radiotherapy. Then pituitary apoplexy, because of sudden hemorrhage of the pituitary gland, which is seen in the case of existing pituitary adenomas at times, present with sudden onset severe headache with visual impairment, that is bitemporal hemianopia. It can be diplopia because of the third nerve involvement or features of hypopituitarism. Pituitary apoplexy occurs in pregnancy, diabetes, hypertension, sickle cell anemia, but it does not occur in hyperthyroidism. In hypopituitarism, hormones are affected in the fall. Now, this is very important. You have to remember this. GGTA. I taught you earlier also the same sequence. So the hormones are also lost in the same order. This is a physiology, like it is a nature's way of protecting the life-saving hormone, that is cortisol, till the end. So growth hormone goes first. So in adults, basically, if the growth hormone is lost, it is not clinically very evident very early. Then comes the loss of the gonadotropins, that is the LH and FSH. And again, in the postmenopausal women or very old men, you may not even realize the loss of the GN, that is the gonadotropins. Then the loss of prolactin. Again, clinically may not be very evident at any age other than lactation, failure of lactation, or loss of libido for men. Then comes the loss of TSH, when the patient starts presenting as secondary hypothyroid. And the last to go is the ACTH, which is going to cause a hypocortisolism, and you will have features of low sugars, low BP. So features because of decrease in hormones, and then features because of mass effect. So because of low hormone, there will be GH deficiency, that is adult GHD. There will be features of gonadotrophin deficiency, that is LHFSH, causing oligomenorrhea or amenorrhea. Thyroid deficiency will give features of secondary hypothyroidism. Corticotrophin deficiency will cause features of adrenal insufficiency. But because it is ACTH deficiency, so there will be no hyperpigmentation. Then prolactin deficiency will cause failure of lactation. Diabetes insipidus is not a feature of hypopituitarism, that you have to remember. So the transaction of pituitary stalk does not lead to diabetes insipidus. Insulin is a pancreatic hormone and is not under the control of pituitary. So hypoinsulinemia causing diabetes is not a feature of hypopituitarism. Transaction of the pituitary stalk does not lead to diabetes mellitus. So diabetes insipidus and diabetes mellitus both will not be seen with pituitary stalk section effect. Mass effects, yes, pituitary tumor causing mass effect, we just read, commonly headaches, biotemporal hemianopia, because of the compression of the chiasma. So investigations for GHD, for GH hypersecretion we did OGTT. For GHD, we will do ITT, that is insulin tolerance test. So we give insulin, usually it is given 0.05 to 0.1 unit per kg, but this is given IV. And once the blood glucose level is less than 54 or less than 40 milligram per DL, that is we call the critical sample, the growth hormone should rise to above 10 nanograms per ml in a normally functioning pituitary. If it does not rise above 10, then we are dealing with GHD, that is growth hormone deficiency. So that suggests growth hormone deficiency. Then we also have metyrapon test. Metyrapon causes reduced cortisol synthesis, which should increase ACTH, but synthesis in a normal person. If we fail to achieve this, we are again dealing with a pituitary failure. So treatment involves hormone replacement. How do you treat hypopituitarism? You just go on replacing the hormones and treat the underlying cause. So you replace the hormones in the reverse direction. Hydrocortisone, if there is hypocortisolism, you give hydrocortisone for the secondary adrenal failure. For hypothyroidism, you replace thyroxine. You will always replace the end organ hormones. You cannot replace the pituitary hormone. So you replace the end organ hormones. So for hypocortisolism, you replace the hydrocortisone. For hypothyroidism, you replace thyroxine. For hypogonadism, you treat the symptoms and prevent osteoporosis. So you can replace with estrogen, progesterone, and even test for males, you can replace testosterone. Coming to the defects of the posterior pituitary, that is diabetes insipidus. Let us understand the basic concepts. ADH, that is anti-diuretic hormone. So it will prevent the diuresis. Anti-diuretic hormone, also known as vasopressin, it is synthesized in the hypothalamus. We just learned that neurohypophysis of the posterior pituitary, it's an extension of the neuroectoderm. It does not produce hormones, it only stores and releases them as needed. So these hormones are basically synthesized in the hypothalamus, specifically in the paraventricular and the supraoptic nuclei. And after synthesis, this ADH is transported to the posterior pituitary for storage and later release into the circulation. ADH is responsible for maintaining the water balance by regulating water absorption from the collecting tubules of the kidney. So ADH acts on the V2 receptors, that is vasopressin receptors, also known as the D2 receptors. So loss of body water increases serum osmolality and causes decreased volume. So there is dehydration. So let us see how a normal concentration of the urine happens. So increase in the plasma osmolality, what will happen? It will stimulate anti-diuretic hormone and prevent the water loss, stimulate ADH synthesis and release. It will absorb the water and concentrate the urine. Now, if the H2O is reabsorbed, water is reabsorbed and brings the increased plasma osmolality to normal, then again, that will happen because once the water is absorbed from the kidneys, the plasma osmolality will become normal. So urine osmolality is always greater than the plasma osmolality. So because it is whatever is, once the body has its own water system in balance, then only you will filter out and lose. So urine osmolality is always greater than the plasma osmolality. This is a normal physiology. Now anti-diuretic hormone or desmopressin, it acts via the V1 and the V2 receptors. So for V1, it is the action on the blood vessels causing constriction and increased platelet aggregation. But for kidneys, it acts via the V2 receptors at collecting ducts, and it will act via the aquaporin 2, 3 and 4 and it will reabsorb the water. At liver level, it helps in the release of factor 8. That is why we are also using it in the hemophilia. At the endothelium level, it causes release of the von Willebrand factor. Now, these physiological changes, they cause increased production and release of ADH via activation of the osmoreceptors in the hypothalamic nuclei and the baroreceptors in the carotids and the atria. So we have the baroreceptors in the carotids and the atria, that is the peripheral receptors, and we have the central osmoreceptors in the hypothalamus. So all this mechanism helps in controlling what? The water balance by managing thirst, the water intake, and urine output, and the water lost. Now coming to DI. So by definition, it is the passage of large volume of urine. So if the urine lost is more than 3 liters per day of the dilute urine because of impaired water reabsorption by the kidney, because of the decreased ADH secretion from the posterior pituitary, we call it central DI or the cranial DI. Or if you find there is impaired response of the kidneys to anti-diuretic hormone. Suppose there is normal ADH, but it is not able to work. Then we are dealing with nephrogenic DI. Now, if the ADH administration repairs the defect, so we are dealing with central DI. If the administration of ADH fails to repair the defect, we are dealing with nephrogenic DI. So the blood sugar is normal. We are not dealing with sugars here. In diabetes insipidus, the plasma sodium concentration is very, very high. So hypernatremia is a hallmark feature of diabetes insipidus. Urine is always diluted and never concentrated. So you will find here that the urine osmolality is less than plasma osmolality. If urine osmolality is less, you are dealing with diabetes insipidus. Now, increase in the plasma osmolality will cause polydipsia. Patient will be thirsty. Inability to reabsorb the water will cause polyuria. So polyuria with polydipsia with hypernatremia because of the loss of the pure water. There is loss of sodium, the conservation of the sodium. There is only loss of total body water. The total body sodium is normal, but it is the total body water which is lost. So there is hypernatremia. So plasma osmolality is rising, whereas urine osmolality is low. So dilute urine which is passed. Causes of cranial DI, it is most commonly idiopathic, or it can be congenital, X-linked recessive, that is a Didmore syndrome, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, that is Didmore syndrome, also known as Wolfram syndrome, because of the Wolfram gene defect. Now the tumor, it is a craniopharyngioma causing the DI mostly. Trauma can cause DI or the central DI, hypophysectomy and head injury, infiltration of the pituitary by histiocytosis, sarcoidosis, vascular injuries like the Sheehan syndrome, hemorrhages, infections like meningoencephalitis. Causes of nephrogenic DI, mostly it is drug-induced. That is, lithium can cause nephrogenic DI, demeclocycline, methoxyfluorine, amphotericin B, aminoglycosides, and cisplatin. These antibiotics are known to cause, antifungals and antibiotics are known to cause DI. Lithium is one of the very common cause. Lithium is used mostly in the antipsychotic managements. Then chronic renal disease at times, post-obstructive uropathies, hypokalemia, and hypercalcemia. Now, how to approach a cause of polyuria? If a patient is presenting to you with a urine output of more than 3 liters in 24 hours per day, more than 3 liters, then you measure the urine osmolality first, should be checked. If the urine osmolality is less than 250, that is a dilute urine, probably you are dealing with diabetes insipidus. But if the urine osmolality is high, you are probably dealing with solute diuresis. That means you are dealing with diabetes mellitus, that is glycosuria. There is high osmolality. Now, the first thing to do is, if you have a urine osmolality of less than 250 and you're suspecting DI, the first thing is go for water deprivation test. Stop the water intake of the patient. So the moment you stop the water intake, and if it is DI, the urine osmolality will not change, but the plasma osmolality will rise. But if it is a polydipsia, that is a psychogenic DI, that is a polydipsic DI, the moment you stop the water intake, the urine osmolality will start rising because the body will start conserving water and stop losing water. So if this patient is hospitalized and his water intake is stopped completely, the urine output is reduced, and that indicates psychogenic polydipsia or a psychogenic DI. If the patient is still losing a lot of urine and the osmolality is still low, after the water deprivation, you go for administration of desmopressin. So if the urine output is still high, then inject desmopressin. Injection ADH is given, that's a desmopressin, short-acting ADH. Now, if the patient's urine output is reduced after injection, that means that we are dealing with central DI. So there was ADH deficiency, you replaced ADH, and the urine output is now decreased. But if the urine output is still high, then you are dealing with nephrogenic DI, that is, there is a receptor defect. So this is a summary, just revising the same thing. In a normal condition, urine osmolality is more than 800. If it is a neurogenic DI, it will be less than 300 or 250. If it is a nephrogenic DI, it will be somewhere in between. If it is a primary polydipsia, it will be more than 500 anyways. Now, this is a water deprivation test. Once you give vasopressin injection, in case of normal person, the urine output will still be decreased. In case of neurogenic DI, the urine osmolality will increase by 50%. In nephrogenic DI, it will not respond, whereas in primary polydipsia, again, the osmolality will change by increase by less than 10%. Serum sodium levels, there is hypernatremia. Normally, the sodium is between 135 to 145. In case of central DI, there is hypernatremia. In case of nephrogenic DI, again a hypernatremia. But in case of polydipsia or a psychogenic DI, the serum sodium is not raised. Rather, there is a dilutional hyponatremia because the patient keeps on drinking plain water. So this is again a recapitulation of the same table. So treatment for central DI, you treat with desmopressin, that is a synthetic analog of ADH. In case of nephrogenic DI, you treat the underlying cause. Treatment with conventional doses of thiazide diuretics or amiloride in conjunction with the low sodium diet or a prostaglandin synthesis inhibitor, that is indomethacin. It will reduce the polyuria and polydipsia. Nephrogenic DI is treated with thiazides. Volume depletion decreases polyuria because of the increased reabsorption of sodium and water from the proximal renal tubules. Urine osmolality more than 300 means solute diuresis, that is diabetes, glycosuria is there, or you are losing proteins. So serum sodium, serum osmolality is usually increased. During solute diuresis, more water is lost than sodium, thereby it causes hypernatremia and hypertonicity. Solute diuresis examples are diabetes, mannitol, urea, resolving ATN, that is acute tubular necrosis, and the medullary cystic disease. Last minute revision points. Urine osmolality, less than 250, we are dealing with diabetes insipidus. Low serum sodium, low osmolality. Everything low, we are dealing with psychogenic polydipsia. Increased sodium, increased osmolality, we are dealing with diabetes insipidus. Administer vasopressin, that is desmopressin. Urine volume less, osmolality increased, that means again central DI. If no effect on urine, then we are dealing with nephrogenic DI. Treat with thiazides or amiloride. Golden line to remember, during a water deprivation test, most patients with primary polydipsia will demonstrate a significant increase in the urine osmolality. Patients with primary polydipsia will have low serum sodium levels and osmolality. Restriction of the water intake will normalize the output in patients with primary polydipsia. Anytime a patient has bitemporal hemianopia, a pituitary tumor should be suspected. The most common functional pituitary tumor is a prolactinoma. Secreting prolactinomas inhibit the entire axis of the GnRH, LH, FSH sex hormone axis, causing impotence in men and amenorrhea in women of the reproductive age, that is hypogonadotropic amenorrhea. Low bone density, well-known complication of hyperprolactinemia associated with prolactin-induced hypogonadism. Vaginal dryness is another very common manifestation of estrogen deficiency. Now, because of the limited time, I have taken the lecture very fast, very quickly, but you can always go through it again, run it on a slower speed at your own speed. For more learning, you can go through the book Medicine Simplified. The entire lecture is given here. We will be conducting similar classes on Zoom every Tuesday and Thursday. Next week, we will meet again with lectures on thyroid lecture 1 and thyroid lecture 2. That is Tuesday and Thursday, 18th and 20th. We will complete thyroid. This is the syllabus for endocrinology. We have ticked off this, pituitary done. Thyroid 1 and 2 modules next week, then adrenals, parathyroids, and the diabetes 4 lectures. Whatever remaining topics, if something remains in endocrinology, that is how the hormones act, what is the receptor mechanisms, or if you want to learn more, anything extra in endocrinology, just send a message directly to us. We will cover in the miscellaneous lecture. Then, of course, new year, we will begin with nephrology. Once again, download the app for free videos. You can follow us on YouTube. You can follow us on Insta. You can have our social media handles at Facebook also. For any further queries, you can message on any of these numbers. You can drop us a mail at any of this ID, and we will respond back within 24 hours. Thank you so much.